Hello friends. Today we are going to discuss about treatment-resistant schizophrenia, Part 3. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about treatment-resistant schizophrenia related neurobiology. Schizophrenia is a chronic mental disorder, and it affects 1% of the world's population. Majority of the schizophrenia patient has lifelong illness. Schizophrenia is considered to be a heterogeneous disorder with multiple factors involved in etiology of schizophrenia. The multiple factors are genetics and also environmental factors. Schizophrenia is characterized by positive symptoms, negative symptoms, cognitive symptoms, and also disorganized symptom. Schizophrenia causes severe functional impairment. Unfortunately, all patients with schizophrenia do not respond to medication. Research have clearly showed that 25 to 35% of the patients with schizophrenia do not respond to medication. In treatment-resistant schizophrenia, clozapine is the only drug which is considered to be gold standard and has been approved by FDA for treatment-resistant schizophrenia. When you start clozapine for treatment-resistant schizophrenia, 40% of them will respond to clozapine. That means still 60% do not respond. Let's look into the categories of various treatment-resistant schizophrenia. If you take 100 schizophrenia patient and if you start antipsychotic, for the first antipsychotic, 50 to 60% will respond. That means remaining 50 to 40% do not respond. When you start second antipsychotic, there will be improvement by 10 to 20%. That means still 30% do not respond. And that 30% will be considered as treatment-resistant schizophrenia. In such patients, we need to start clozapine. When you start clozapine for treatment-resistant schizophrenia who are 30%, invariably 20 to 50% only will respond. That means the clozapine only is effective in 40% of treatment-resistant schizophrenia. And finally, when we add ECT, still 10 to 15% do not respond. That means this 10 to 15% of total schizophrenia patient can be considered as refractory schizophrenia. And these are the patients who require long-term medication. And also, one person has to stay with him. Invariably, majority of them require continuous care in a halfway home or else in a mental hospital. Let's understand in a simple language. If you take 100 schizophrenia patients, when you start first antipsychotic and then if you try second antipsychotic, still 30 to 35% do not respond. And this 30 to 35% can be considered as treatment-resistant schizophrenia. When you give clozapine, further, the improvement will be around 10 to 20%. That finally, we will be left with 20 to 25% do not respond to clozapine. They are called as ultra-resistant schizophrenia. And invariably, when we add clozapine plus ECT or else any other medication, we will see further 10 to 15% improvement. And finally, the refractory schizophrenia is 10 to 15%, my dear friends. In this regard, there was a 10-year prospective follow-up study of first episode psychosis, which was done by Dimaj and his colleagues in 2017, published in Psychological Medicine. In this study, they clearly pointed out 80% of the treatment-resistant schizophrenia starts from the early stages of illness, and only 20% develop treatment resistance in the future course of time. This is because the frequent relapse and also stopping of medication, poor adherence, substance use cause relapse. If you look at this diagram, you can understand 80% of treatment resistance occurs in the early stage of illness. That means in the first episode only, you can see 80% of them who are treatment resistant will be there. And remaining 20% of the treatment resistant invariably occur after maybe 3 to 4 episodes of relapse and starting of medication. This relapse usually occurs because of poor adherence, comorbidity, substance use, and also drug resistance. That means these are the group of patients who are completely different from the drug responders. These treatment responders are different in many ways. Many of the researchers have clearly said that these are the subset of schizophrenia in which genetics, neurocircuits, and also the neuroanatomy of this brain of these patients are different. Hence, we will look into the neurobiology of treatment-resistant schizophrenia, whether they are same or different from people with schizophrenia. In this regard, there is an excellent article done by Potkin and his colleagues and published in 2020 in NPJ Schizophrenia. The title of the study is The Neurobiology of Treatment-Resistant Schizophrenia, Paths to Antipsychotic Resistance, and a Roadmap for Future Research. I request all the viewers to go through this article. In this article, they have given various hypotheses. I'll be discussing about these hypotheses, and one of the commonest is dopamine supersensitivity hypothesis given by Charnard and colleagues in 1978. If you look at this diagram, in the upper part you can see presynaptic dopamine neuron and postsynaptic dopamine neurons. Here, if you look at this blue color, it is dopamine, and the brown color is antipsychotics, that is D2 blockade. Here in the presynaptic vesicle, there will be dopamine released, and then it goes and attaches to the postsynaptic neurons. However, whenever the antipsychotic is given, the antipsychotics will block the D2 receptors. Here, the effect of antipsychotics is based upon the D2 receptor occupancy. If the occupancy of D2 receptor is in the range of 0 to 60%, then invariably it is not effective. If the occupancy of antipsychotic is in between 60 to 80%, that means we are in the therapeutic window. This is the range where there will be no side effects, but psychotic symptoms start resolving. However, if the D2 receptor occupancy increases by more than 80%, then you will see various motor adverse effects, which are characterized by extrapyramidal symptoms, tremors, and also tardive dystonia, tardive dyskinesia. Hence, my dear friends, to have an effective antipsychotic, you need to have the D2 occupancy in the range of 60 to 80%. Let's understand this dopamine supersensitivity theory. After you give antipsychotics, invariably there will be blockage of D2 receptors. Since there is a blockade, but the availability of dopamine has not decreased, hence the dopamine receptor increases in number. This can be easily seen. Before we give antipsychotics, the number of D2 receptors, which are yellow, are very few. Once we give antipsychotics and the blockade of D2 receptor over a period of time causes increase in dopamine receptor, and this is dopamine supersensitivity theory. Since there is increased receptors and also the dopamine blockage is there, hence invariably it causes the imbalance. Although you are giving antipsychotics, since the receptors are generated more, the patient continues to have psychotic symptoms. Hence, my dear friends, this is the dopamine supersensitivity theory. A critical caveat of dopamine sensitivity hypothesis is that It accounts only for those treatment-resistant schizophrenia that emerges after initial successful treatment with antipsychotic. That means when you give antipsychotics, all the D2 receptors are occupied and there is a remission. After some time, then the patient will have increased receptor formation and supersensitivity, and that leads to relapse of symptoms. However, whenever there is a relapse of symptoms, that should have been accompanied by tardive dyskinesia and also EPS. Unfortunately, that does not occur. Hence, this hypothesis does not explain the patients who have treatment resistance in the first episode only. Hence, this dopamine supersensitivity theory has to be accepted with a pinch of salt. Further, there is dopaminergic subtypes of which have been classified as treatment responsive schizophrenia, which are hyper dopaminergic state, and treatment resistant schizophrenia, normodopaminergic state. In the upper one, you can see the dopamine is produced in large number, and hence there will be increased dopamine will be released. Here the dopamine synthesis in the presynaptic neuron is in abundant, and hence this causes hyperdopaminergic state, and hence this hyperdopaminergic state can cause treatment responsive schizophrenia, and further over a period of time this responsiveness can become treatment resistance also. However, the current literature clearly indicates whenever there is increased dopamine synthesis, they respond well to antipsychotics. However, in the normodopaminergic state, sometimes it is also called as hypodopaminergic state, whenever the dopamine is produced in less in number, like in the diagram here, the patient will have treatment resistance. They will not respond to antipsychotics. Hence, my dear friends, treatment-resistant schizophrenia seen in normodopaminergic state also. If you compare this normo versus hyperdopaminergic states, elevated striatal dopamine synthesis in these neurons, which causing hypodopaminergic state in first episode patient who went on to respond to the antipsychotic, but unaltered dopamine synthesis capacity, that is normodopaminergic in the first episode patient who did not respond to antipsychotic treatment, can be explained here. However, this does not explain all the cases of schizophrenia, my dear friends. Hence, there is an imbalance hypothesis which has been proposed. The imbalance between direct and indirect pathway of dopamine has been proposed. As you see here, from the prefrontal cortex to the striatum, involving thalamus and substantia nigra, the direct pathway and indirect pathway. If there is an imbalance, this can cause treatment-resistant schizophrenia. Further, we will discuss about other neurochemical hypotheses. This is the diagram which explains other neurochemicals involved. Apart from dopamine, glutamatergic neurons, dopaminic neurons, and serotonergic neurons have been implicated in treatment-resistant schizophrenia. Let's discuss all of this. With regard to serotonin hypothesis, serotonin plays a complex role in the modification of dopamine neurotransmission in the brain. It is thought to contribute to the neurobiology of schizophrenia. If you take all atypical antipsychotics, it can be risperidone, it can be clozapine, it can be quetiapine. They do act on serotonergic pathways. There is evidence of lower level of serotonin 2A receptors and higher level of serotonin 1A receptors have been considered with regard to treatment-resistant schizophrenia. But these findings are not robust. Few studies have found positive. At the same time, we also have negative studies. With regard to NMDA receptors to glutamate, studies have shown that NMDA receptors are associated with clinical pathological features of schizophrenia. The development of positive and negative symptoms have been attributed to altered glutamatergic signalization via N-methyl deaspartate receptors. That means glutamate plays a role through NMDA receptors and causes treatment-resistant schizophrenia. NMDA receptor dysfunction on GABA interneuron results in disinhibition of critical, cortical, or hippocampus glutamate neurons projecting to the basal ganglia. This results in treatment-resistant schizophrenia. This hyperactivation of glutamate neuron in turn stimulates the activity of dopaminergic projection from the midbrain to the striatum, resulting in positive symptoms of schizophrenia. However, the presence of more positive symptoms indicates for better response. Hence, the glutamate hypothesis cannot explain completely with regard to treatment-resistant schizophrenia. High doses of glycines open NMDA channels and thus could counteract a hypoglutamatergic state, but studies are inconclusive with regard to high dose of glycine in treatment-resistant schizophrenia. Glutamate release inhibitors such as lamotrigine or topiramate did not alter the clozapine responsive status in few studies. However, in few studies, clozapine augmentation with lamotrigine has found to be very effective. Further, neuroinflammation and oxidative stress have been proposed for treatment-resistant schizophrenia. Postmortem studies in patients with treatment-resistant schizophrenia has reported signs of microglial activation, indicating inflammatory response in the brain of treatment-resistant schizophrenia. Elevated levels of pro-inflammatory cytokines have been found in the blood and cerebrospinal fluid of treatment-resistant patient. These cytokines can impact neurotransmitter system and contribute to the neurodegenerative process. This neurodegenerative process over a period of time can cause negative symptoms. Neuroinflammations early in the life, especially in the childhood onset schizophrenia, followed by chronic overactivation, has been hypothesized to contribute to the etiology of schizophrenia. It is possible that a high level of inflammation, especially in childhood, plays a role in treatment resistance. Now the question comes is, how did this neuroinflammation occur? Of course, it can be because of immunity altered response. This altered response can be because of environmental triggers. It can be virus, it can be bacteria, it can be non-specific immune disorder. Further, oxidative stress, as measured by the lipid peroxidation, was elevated in patients with treatment-resistant schizophrenia compared with the patient treatment-responsive schizophrenia and healthy control. All these studies do indicate with regard to neuroinflammation. Now let's move into genetic studies. Researchers have suggested that treatment-resistant schizophrenia may be related to increased genetic loading or genetic burden. Studies have clearly indicated the patient who do not respond to treatment have found to have more number of schizophrenia in their family. That means family history of psychosis in the first degree and second degree increases the genetic vulnerability and burden on this patient. One of the genes that have received considerable attention in treatment-resistant schizophrenia is COMT. That is, catechol O-methyltransferase have been implicated. Polymorphism of COMT gene are associated with difference in dopamine transmission and have been implicated in cognitive and clinical profile of treatment-resistant schizophrenia. However, study comparing gene expression among patients with treatment resistance, patient with treatment-resistant schizophrenia, and also responsive, and also healthy control found no difference between three groups. All of them had similar candidate gene across treatment-resistant schizophrenia, treatment-responsive schizophrenia, and normal, healthy control, including CVMT gene, was negative, and this study did not implicate any gene, including candidate gene approach. Further, a combination of dopamine transporter and serotonin transporter gene, that is variable number of tandem repeats, have been implicated with regard to polymorphism, has been associated with treatment-resistant schizophrenia. Now, we do not have exactly how many number of genes are involved, how do they play a role, what is the role of environment, when do they trigger, how do they happen, why the patient responds initially, why the patient does not respond later. All these need to be unraveled. There is still a long way to go to understand the genetics of treatment-resistant schizophrenia. However, the epigenetics has been found to be playing some role. Epigenetic alterations such as DNA methylation and histone modification can influence gene expression without altering the DNA. Now the question is, how does this epigenetic alteration occurs? These changes have been linked to regulation of genes involved in neurotransmission, neurodevelopment, synaptic plasticity, all of which are relevant to schizophrenia and potentially to treatment-resistant schizophrenia. Now the question is again, how does this alteration in DNA methylation and histone modification occurs? These again occurs because of environmental toxins or hostile environment, stress, substance use, drug abuse can cause this modification and hence treatment-resistant schizophrenia, my dear friends. Further, various researchers have looked into neuroimaging studies. Evidence from structural magnetic resonance imaging studies indicated that patients with limited response or treatment-resistant schizophrenia had increased cortical atrophy, especially dorsolateral prefrontal cortex, and reduced gyrification in comparison with patients who responded to treatment. So, in simple word, the patient who responded to treatment did not have any decreased cortical atrophy, whereas in treatment-resistant, cortical atrophy was classically seen. Further, the two comprehensive review with regard to neuroimaging studies looking at the treatment-resistant schizophrenia focused and showed the functional imaging studies clearly indicated decreased metabolism in the prefrontal and frontotemporal region. Further, hypermetabolism in the basal ganglia in treatment-resistant patient has been found in these meta-analyses. Further, other areas of the brain which have been indicated are greater gray matter reduction in frontal region, increased white matter volume, reduced striatal dopamine synthesis, elevated glutamate concentration in the anterior cingulate cortex are all involved in treatment-resistant schizophrenia. Increased striatal dopamine synthesis, that is, higher level of striatal dopamine synthesis indicated treatment response. In reverse, that is, decreased striatal dopamine indicated treatment resistance. So, my dear friends, there are some neurobiological changes which have been implicated. There are few subtle structural changes have been noted in MRI studies, hypofrontality, dopaminergic dysregulation, glutamatergic dysfunctions have been implicated. To summarize the neurobiological findings, the first hypothesis proposes that treatment resistance is characterized by normal dopamine function, while glutamate or other pathways contribute to the distinct neurobiology of treatment-resistant schizophrenia. The other hypothesis proposes that dopamine supersensitivity, that leads to the development of treatment resistance over a period of time. It is essential to recognize that two models are not exclusive. The combination of both may be playing an important role in treatment resistant schizophrenia. Hence, schizophrenia is considered as a heterogenetic disorder with combination of various factors, that is neurochemical factors, neuroplasticity, environmental factors, genetic factors. All of them play a role in development of schizophrenia. If you look at this diagram, it clearly indicates what are those important factors which causes treatment resistance. First and the foremost is increased family history of schizophrenia, that is heavy loading of genetics, obstetric complication during the birth, low premorbid level of functioning, excessive neurological soft sign, reduced garification, greater genetic burden, longer duration of untreated psychosis, younger age at of onset, negative symptoms, normal presynaptic dopamine and increased dopamine in anterior cingulate and glutamate can cause treatment resistant schizophrenia. Thank you very much for giving your valuable time. Stay safe.